is on trauma and stressor-related disorders. And these are coming from traumatic events or stressors that can occur in many people's lives. Characteristics are that they experience some type of extraordinary thing that is intense or severe, and these stressors are well beyond the stress of daily life. So I'm trying to think of some things that have recently happened. We had a shooting there at a mall just a couple of days ago in a Macy's. So you can imagine if you were experienced that would be traumatic for you. People that have witnessed bad accidents, or they've helped with an accident where they're not used to that kind of situation, can be traumatic. We know our folks that have served in the military in that capacity oftentimes can develop stress-related type syndromes, loss of a child, abuse as a child, and you can think of many other things. You yourself may have experienced something that you would say to yourself, I hope nobody ever has to experience this in their life. That's an extraordinary or an intense exposure to some type of traumatic event. So examples: abuse, illness, victim of a crime, a robbery, something like that, some type of group trauma or stress. There's war, natural disasters, community loss, maybe the death of a prominent citizen, something like that may have caused it. So characteristics of when stress and trauma can become a disorder. Well, there's poor coping abilities. You have difficulty managing stress. There's emotional difficulties. Those things interfere with the activities of daily life. Maybe you're unable to maintain your job. Maybe you can't get to school. Maybe you can't care for yourself or even your family members. Other symptoms that patients or folks that have experienced this might be anxiety, insomnia, fear of going to sleep because something might happen, or they are in the grief, those stages, and they never are able to progress. We can have adjustment disorders, depression, as mentioned in your book, complicated grieving, without proper support groups, support people around you, that can be an issue. Acute stress disorders, so they have physical issues. Post-traumatic stress disorder, PTSD, is in here. One of the cautions that your book does give you on PTSD is that oftentimes people report they have PTSD, but they've never actually been officially or clinically diagnosed. So you want to be a little cautious when people say they have PTSD, that they get a professional diagnosis of that, because it could be something else that could have been a little more easily treated if they would just seek out a little bit of guidance for that. So that is one thing that your book points out, is that a lot of people do claim to have PTSD, but it's never officially been diagnosed. And then dissociative disorders, these are a response that occurs in response to some type of, again, traumatic event. We can have dissociative amnesia, where you forget about the event. We can have dissociative identity disorder. These are where people have two or more distinct identities. We formally call that multiple personality disorders. So those are other areas that we also can look at. There are some good movies out there. So when you're looking for extra credit on dissociative disorders, there's some interesting ones out there on those multiple people with multiple personalities. So those are good ones and interesting ones to watch and mark down for extra credit. So other patterns of behavior that you might see for folks that have experienced some type of trauma or stress might be intense memories of the trauma. So some of our folks, The insomnia comes from not wanting to fall asleep, because when they fall asleep, they dream of the issue and it's disturbing. Flashbacks. I know that sometimes you'll see folks when it becomes 4th of July, you'll see not only things because of fireworks related to animals that have emotional issues related to the loud sounds, but truly diagnose some of our PTSDs from being in combat, where you hear the fireworks going off, can remember them of bombing, shells, those kind of things. So it'll say, be kind to our folks that suffer from that type of PTSD, because those can bring back flashbacks or intense thoughts of what it was to be in that circumstance. Emotionally numbing, increased irritability, or it can be a hyper arousal of the patient. So PTSD, the behavior is demonstrated by someone who experienced, witnessed, or was confronted with a traumatic event. And we've talked about those. It can be anything from war to a shooting to an unexpected death to being in a car where, you know, your driver or your family member, somebody was killed, but yet you were not. Things that lead, that experience the trauma can lead to, there's your dreams or your intrusive thoughts, emotionally numbing, so you detach from others, hyperarousal, you're being on guard all the time, or you're irritable. And there is a checklist for PTSD that they can go through with patients to see how many of those things that they meet. Acute stress disorder versus PTSD. The event has occurred in less than 3 months, and a PTSD is the event occurred over 3 months or greater. PTSD is chronic with periods of exacerbations, especially if there's increased stress. PTSD can lead to other psychiatric disorders such as depression, anxiety, and substance abuse. 25% of our survivors of physical assault have some type of PTSD. 70% of survivors of rape have been diagnosed with PTSD, and it can occur in children and adults and older adults. So it isn't just, you know, that 20 to 50-year-old, it can really cover the whole lifespan. Predictors or risk factors to PTSD: they were directly involved in a traumatic event, they experienced some type of physical injury, there might have been a loss of loved ones, they don't have a lot of support. So that's a big factor. People have went through and will continue to go through traumatic events in their life. But why do some people develop PTSD and others do not? I retrospect on, if you think back to like World War I, World War II, and you had a lot of young folks that went to war and thousands never came back, or they experienced traumatic events, and yet you did not, I mean, we probably didn't know what it was back then, but you didn't hear a lot of people of having issues. Was it because we had a lot more support? Families were still families back then. You had extended family members. You came back home and you were reintegrated fairly easily. And now we don't have that as much. You know, you kind of wonder what's happened. Why do we have more PTSD in our lives than what we did? And it isn't because people didn't have traumatic events in their life. They just, I don't know. I guess we experience things differently. Just food for thought. Just kind of, I've always kind of wondered that why back then did they not have as many issues, or maybe they did and they just kept it hush hush. I guess maybe that's something that I should consider also. And then, do they have any previous psychiatric history or personality factors that may keep them from effectively dealing with this? Adolescents are more likely to develop PTSD than children or adults. Um, Again, their age, gender, type of trauma, repeated trauma all play a role in that too. And I think our adolescents don't have very good coping skills these days with how to deal with almost anything. Adolescents suffering from PTSD do have increased risk for suicide, substance abuse, poor social supports, academic problems, health concerns. I know we had a poor soul the other day in the emergency room that was 14 with suicidal ideations. And I just think how sad to be 14 and be so depressed or so anxiety ridden that suicide is your only means of getting out of a situation. Some treatment options then for PTSD, individual or group therapies, again, medications such as antidepressants, anti-anxiety, sleep aids, self-help groups, exposure therapies, relaxation, adaptive disclosure, cognitive process therapy, and you can kind of read through those. Again, the patient has to be willing to accept their diagnosis and be willing to accept treatment. It's just like the alcoholic, it's kind of hard to push people into treatments. You have to be willing to accept treatment and want to better yourself or get through it. The next one that the book talks about is disassociation, and I kind of highlighted that. It's a defense mechanism, a subconscious one, to prevent the recognition of that horrific or traumatic event. This allows the person to forget or remove himself from the situation or a memory of the situation. They have a disrupted integration of consciousness, memory, identity, environmental perception. People with dissociative disorders, they can have pathological issues. Oftentimes it's involuntary. They really don't even know they're doing it. It can lead to problems with relationships, your ability to do the activities of daily living, your basic ability to cope, and people with PTSD often do experience dissociative symptoms. Kind of that denial or that erasure of a memory. Three main types that your book talks about. We talked about dissociative amnesia. We talked about personality disorders, or not personality disorders, but multiple personality issues, and then depolarization. And this is where the client has a persistent or recurrent feeling of being detached from his or her mental process or body. So they're kind of like out of touch. They always seem like they're in a foggy or unreal environment. They're not psychotic. They're not really out of touch of reality, but they just are unable to be very engaging. So what do we do for our patients? Well, for our dissociative disorders, individual group therapies, same medications as our PTSDs, our antidepressants, our anti-anxiety medications. Well, we want them to be able to participate in life, so we need to improve their quality of life. We need to improve their functional abilities. We need to be able to make sure that they can do their activities of daily living, that they can participate in work, school, whatever needs to be done, and that they have decreased symptoms. So what are some assessments that we do? Well, what is their history of their trauma or their stress or their abuse? When did it occur? And then just observation of the patient. What do they look like? Are they hyper alert? Are they anxious, restless? Do they have an increased personal space, meaning if you get too close to them, they're going to back off? Fetal positioning, that would be extreme. But you know, you see things on TV and you hear about some of the abuse that happens, and you just wonder, how does anybody even continue on from that? Their mood and affect, from passive to angry, frightened, agitated, hostile. Do they have flashbacks, fantasies, self-destructive thoughts, hallucinations? Do they have memory gaps where they can't remember what happened? Do they have poor decision making? How about their roles in relationships? Are they integrated into a personal relationship, man, woman, man, man, woman, woman, whatever it may be? Are they able to go to work? Are they able to maybe even go to school if that's what they're doing? Can they socially interact, or they seclude themselves in their house? How do they take authority figures? Or do they have a problem with that? I think of Rambo, right? The movies Rambo. Didn't he have PTSD essentially? And then when you got into areas with authority and stuff for people telling him what to do, he did not handle that very well. We can have disturbed sleep, change in appetite, and oftentimes how our patients will deal with this will be alcohol or drug usage. So what are some nursing diagnoses then for these disorders? Risk for suicide or self-mutilation, ineffective coping, post-trauma syndrome, powerlessness, chronic low self-esteem, risk for self or other directed violent behaviors. And then you can read these others. Our focus would be to improve our self-esteem and promote empowerment, showing them that they're a survivor rather than a victim of the circumstance. Identification of flashback triggers, so what triggers those bad memories to come back. Not that they can't remember them, but what causes them to go into that shutdown mode when they're having those. Encourage journaling of feelings. That's a good one because they're able to read back and reflect on it. And then using distractions or relaxation techniques when those feelings do come about. Self-awareness issues. Here we go. Self-reflection upon yourself as the nurse or the healthcare provider. Being comfortable asking patients about abuse, trauma, or stress. Listening to accounts from patients and families. God bless you if you end up being a sane nurse or you're working in the emergency room where you deal with patients that come in with a lot of abuse. Mental health facilities where you deal with patients that have a lot of trauma and abuse. It takes its toll on you emotionally to listen to these accounts of patients, families, children, that kind of thing. So yeah, I appreciate the folks that have that in them to be able to do that. Recognizing the patient's strength, not just their problems. Dealing with your own feelings. Maybe you've suffered abuse. Maybe that's why you became a nurse. Maybe there's been some traumatic event. Maybe you've been involved in some type of natural disaster. And then, of course, maintaining confidentiality, because when somebody confides in you some type of past trauma, some type of rape, something like that, it's not something that they want to be shared publicly with everybody. Okay, again, there are some questions at the back of your chapter. Probably most of your focus for your test questions will be related more to your PTSD, because all of those can fall into depression, anxiety, etc. So they flow into our other chapters very well. If there's something out of the ordinary when I review the questions for the test, I will email you or let you know. But I would say your focus, for the most part, will be on the PTSD portion of it. All right. So the last chapter, and we kind of did 11, 13, and 12 because